Mike Gibson, Thomas Crawford, and we're coming to you live from MHYH 2024, talking about an interesting topic, the use of reconditioned pacemakers versus new pacemakers in a randomized trial. Thomas, talk to us about what you found.
All right, great. Well, first of all, thank you for having me on. We all know that there's a great disparity in access to cardiac care in the high-income countries and the low-income countries. And there are many reasons for this, but one of the reasons is the high cost of things like stents, valves, and pacemakers and defibrillators. For a number of years now, at the University of Michigan, we have been looking into whether it would be possible to reuse pacemakers that we obtain from the funeral industry, and whether such practice would be safe for patients who cannot afford getting a pacemaker in low and middle income countries. Many patients currently in the global south are not getting pacemakers that they need. And as we know, pacemakers are approved as single-use devices, and the FDA prohibits their reuse. And so one of the things that we've been studying is the ethical and regulatory issues that surround this. But pacemaker reuse is something that our colleagues have been doing in low and middle income countries for a number of years to treat patients without financial resources. When we talk about a pacemaker use, there are two main concerns that emerge. One is the risk of infection, and the other one is risk of malfunction. Until our randomized study, there have not been a single randomized prospective trial evaluating the safety and efficacy of pacemakers that are reused. There have been studies that are cohort studies, mostly retrospective, that show that the infection rate is not statistically different between the two cohorts. So we created a protocol under which pacemakers are decontaminated, cleaned, functionally tested, and packaged and sterilized. We received an export permit by the FDA to allow us to export these devices for a clinical trial in countries that approve it. And we've received those approvals from several countries in Africa and South America. And these include Sierra Leone, Nigeria, Kenya, Mozambique, Mexico, Venezuela, and Paraguay. And so what we're doing at this point is we're presenting the 90-day results. We randomize patients with class 1 indications for pacing to getting a new device versus reconditioned device. The study was designed as a non-inferiority study. The primary endpoint in the study was freedom from procedure-related infection, and the secondary endpoint is freedom from pacemaker malfunction or unexplained death. We enrolled almost 300 patients across those 7 countries. Most patients had complete heart block. Some had sick sinus syndrome or bifasicular block with syncope. The most common complication was lead dislodgement, which was found at a relatively high rate of 5 to 7%, higher than expected, but not different in the two groups. The primary endpoint issues, such as the infection risk, was 3% in the new pacemaker group and 1.5% in the reconditioned group. So it was actually lower in the reconditioned pacemaker group over the new pacemaker group. The difference was not significant. We've basically found that at 90 days, the reconditioned pacemakers are non-inferior to new pacemakers in terms of the infection or device malfunction, since there were no device malfunctions.
So what's the next step? What's the next step then, Thomas? I mean, is this ready for prime time?
Well, so we certainly need to get follow-up from the clinical trial, and we'll present our major results at 12 months. And then we'll follow the patients in a registry after that. What we actually are trying to do is create a blueprint of how to reprocess devices, and using a standardized protocol, we want to, show the world that this is how you can do it, and this is how you can make it a safe practice. And so our sincere hope is that we can bring this into the mainstream of care in the Global South for patients who otherwise just have no access to this therapy. Our next endeavor will be to study ICDs, which are even higher value devices. There's many issues surrounding that, but this is sort of what we are planning in the next few years.
Wow. Congratulations, Thomas. This is really, really, I think, groundbreaking work from a public health perspective. Congratulations. Thanks from all those patients down under who could really benefit from something like this. Thanks for sharing and thanks for joining us today.
Thank you very much. Appreciate it.
Yes.